6 years. He and his wife and 7 kids enjoy living in the Ogden area and all the outdoor opportunities here, and he has been a great resource to have. So let's welcome Dr. Callister.
Appreciate the opportunity to be here. And it's interesting, I was thinking as I listened to Dr. Dames describe the expansion of her field. Happily, part of my field is contracted. And the need to do some of the complex rheumatoid reconstructions has really reduced dramatically. My topic today is some frequently missed or confusing diagnoses, and I'm focused on the upper extremity. And a couple of themes to keep in mind are we don't want to miss things that matter. I mean, it's impressive to maybe make an academic calling where something's rare, but, you know, it's interesting, but it's not going to really affect patient care or outcomes. I want to focus on some injuries that I still see quite commonly that are missed, and when they're missed, it can really compromise a patient's outcome. And another theme is to talk about some injuries that are confusing and similar. And in these cases, one of the injuries or diagnoses is trivial and really doesn't even need a referral, whereas the other may need surgical attention. And so with that in mind, we'll plow ahead. I've kind of picked a top 10 list. We may not make it through it. But first of all, I want to talk about lacerations to the hand. And I think this can be a frustrating problem because you're in an Instacare, it's 8 o'clock at night, and mom has just been cutting tomatoes and lacerated her finger. And there's numbness, or she can't move it just right. And what do? There's no hand surgeon on call. He's off goofing around somewhere. And it's a real frustrating dilemma. First of all, if there's any kind of laceration on a hand, exam is first and foremost. And one of the problems I see is in an effort to make the patient comfortable, you inject local anesthetic, and now the nerve exam is out the window. And that's really pretty critical because if I go in to explore a hand that's been lacerated, I don't want to spend any time looking for something that I know is intact. You've got 2 arteries, 2 nerves to any finger, and if one of the nerves is intact, I want to know that ahead of time because I'm not going to go looking around over there to see if it's intact, if I can tell that from an exam, because potentially you could compromise that artery. And if the other artery's been cut, I mean, that's a problem. So there's a real simple, and many of you have heard this before, but there's a real simple way to test this, simply using a paperclip. And a 2-point examination is really only relevant at the fingertips. It's not something you'd use on the back of the hand or the forearm or anywhere. Your fingertips have the highest density of sensory receptors, and so you simply take a paper clip, and there's no origami here. You just take it and bend it like that. It's like a 2-second process. And interestingly, that ends up being like 7 or 8 millimeters, which is a perfect distance to check 2-point discrimination. So if a patient has had a laceration anywhere on the palm, the wrist, the finger, on the palmar aspect, bend a paper clip and touch the patient's finger on one side and just ask them if they feel 1 or 2. Close your eyes. Do you feel 1 or 2? I'll do this on the normal hand because patients invariably are sort of confused. They don't know what you're asking. And I'll show it to them, and as I say, tell me whether you feel 1 or 2 points. It's a very simple exam, and you'll pick up any digital nerve lacerations. I saw a complete median nerve laceration in the mother of a very prominent citizen here. It was completely missed and sewn up. In fact, there were some stitches stuck right in the nerve. And, well-meaning care, but really shouldn't happen. And a simple exam for sensation will avoid that. And if there is a deficit, then simply apply appropriate wound care, close the wound with a few sutures, and that patient should be referred for surgical care within a few days. Interestingly, when you repair a nerve, it's actually easier to do technically a few days after the injury because when you're repairing digital nerves, it's microsurgery, and the sutures will hold in the epineurium a little better after a day or 2. I mean, you can repair them acutely, but there's really no downside to repairing a nerve 3 to 5 days after the injury. If you pass 7 days, or 10 days really, you're starting to compromise the outcome. Then you avoid NPO issues. And one thing to prep the patient, So you don't end up in this situation of coming back, the patient's traumatized, am I ever going to be able to use my hand again? And you say, well, I called and no one's available in the hospital. I mean, they don't need to hear that, and it's really not accurate. If you reassure them, look, we're going to splint you tonight, apply appropriate wound care. That wound's closed within 30 minutes. They're not sitting around waiting for an operating room for 6 hours with an open wound. And that you'll be taken care of within a few days. Entirely appropriate care, and I think can avoid the awkwardness of the patient feeling like they're getting second-rate treatment because, quote, someone's not available, as opposed to being done in the middle of the night where no one knows where the right instruments are. And I mean, it's just not ideal circumstances. So wound, digital nerve lacerations, or any nerve laceration, easily picked up by a sensory exam. And one of the caveats is there's a tendency to say, do you feel this? And light touch. Light touch can be very deceptive because if you move a finger that is completely, it's had both nerves cut, they have no feeling, if you move the finger, the patient knows you've moved it because of proprioception. So there's a tendency to come in and say, can you move your fingers and can you feel this? And that oversimplification will miss very significant injuries. And along those lines, a flexor tendon exam, there's 2 tendons to each finger. Just to recall the anatomy, the superficialis tendon flexes the PIP joint, and the profundus tendon comes right up through a split in that superficialis tendon, goes all the way out to your distal joint. And so each finger, if you're going to examine a hand that's been lacerated, a finger that's been lacerated, you've got to look for 2 tendons in each finger. And the mechanism of injury could either be a laceration or an avulsion. A jersey finger occurs when somebody is flexing the fingers and it's forcefully extended, and it'll pop that flexor tendon off of the distal joint. In 10 years, I've seen 1 case of a superficialis being avulsed. It's very rare. But a closed avulsion of a profundus tendon is not an uncommon injury. And the way to test this on exam is interesting. We're taking advantage of the anatomy because the profundus tendon that goes out to your distal joints is kind of the ego or brute force tendon. It's got a common muscle belly up in the forearm, and with the exception of the index finger, you don't have individual control of each of those distal joints. It's an all or none. When you flex your hand, you've either got to flex all of them at once or you can't flex it. Now we take advantage of that to test for the superficialis tendon, because if you do it on your own hand, if you grab your fingers, your index, ring, and small finger, and you hold them in extension, and you try to bend your middle finger, you really have no control over that distal joint because you've isolated the superficialis tendon by taking profundus out of the picture. So a very quick and easy exam, you hold all the fingers in extension. Now the interesting thing on the index finger is a significant number of people have an independent profundus tendon. And so on the index, when you hold it straight, some people can still flex that. Sort of a minor point. But on the other 3 fingers, if you hold the others in extension and you flex that, easy way to test for the superficialis tendon. And on the other hand, to test for the profundus tendon, they've got to flex all their fingers at once. And interestingly, I've been referred a number of times a jersey finger which wasn't a jersey finger, because either the physician inadvertently was kind of holding the other fingers while they were examining the injured finger, or the patient is holding their other fingers, they're concentrating, they're holding their other fingers straight. They're going, I can't bend the last joint. It's not because they've got a tendon laceration. They're simply not allowing the other distal joints to flex, and so it looks like a jersey finger, when in fact it's not, and I've seen that a number of times, actually. So briefly, nerve exam, flexor tendon exam for any palmar laceration is pretty simple and quick, and yet I still see a number of these missed, and do it before you give them the anesthetic. Referral is totally appropriate within a few days, and reassure the patient from the outset that that's normal treatment and it's okay, and they don't have to feel like they're being neglected or not getting the best treatment. Another injury I'll talk about is a distal biceps tendon rupture, which demonstrates a few interesting principles. The eccentric mechanism of injury is what usually occurs for any tendon avulsion. And what eccentric means is you've got a muscle contracting. Say your biceps. The muscle is under tension, it's contracting, and something forcefully extends that joint, opposing that muscle contraction. And it's usually a fairly quick force. What I typically see with a biceps tendon rupture is some guys moving a refrigerator with a hand truck up onto a pickup, and the thing shifts. So he's got all this tension on his biceps muscle. There's a sudden load which forcefully extends it, and it pops right off. Same thing happens to your Achilles tendon. Playing racquetball, your gastroc soleus is firing, and suddenly your whole weight comes down on your ankle and stretches that Achilles while it's under tension. That's what happens with a profundus tendon and a jersey finger. So that common mechanism of injury, an eccentric mechanism, is usually how tendons get avulsed. And so when people avulse their distal biceps tendon, it's kind of like an ACL. They typically hear and feel a pop. I mean, they know something happened. It's an acute event, and most of the time they can report in their history they felt a pop. And really, this is one almost like an ACL that you can diagnose largely on history. They tell you, man, I was moving this thing, and it weighed a lot more than I expected, or it shifted. You know, I had a guy just the other day, he was falling, reached out, tried to grab a railing, and his full body weight extends his elbow as he's trying to pull back. And by history alone, you can pretty much diagnose it. Now, on the exam, the real key to this is resisted supination, because everyone thinks biceps, elbow flexion, but in fact, your biceps is your primary supinator, palm up. You've still got a brachialis. The brachialis is a big, strong elbow flexor. Your elbow flexion is just fine. We don't have to repair a biceps tendon to restore elbow flexion strength. The brachialis is plenty strong, and as someone who has a distal biceps tendon rupture and you don't repair it, they still have good elbow flexion, strong elbow flexion. However, you'll lose 50-60% of your supination strength if you don't repair a distal biceps tendon rupture. And on the exam, supination, resisted supination, you tell them, okay, try to turn your palm up, and that's going to hurt. They'll really wince, and they'll be weak. And then compare pronation, and they'll be surprisingly strong. So it's not simply that they're hurting from moving their elbow. It's a very specific test. And when you check elbow flexion, oftentimes it's pretty strong. And they're even a little surprised. You'll be surprised. It's still strong. But the resisted supination is weak. It's tender. And the proximal retraction, when you tear your distal biceps, your muscle is going to move up the arm a little bit. It's not always that obvious. If they get a complete rupture, it may be up the arm 2 or 3 centimeters compared to the other side. But very often, the lacertus fibrosus is still intact, or they've got a few fibers still intact on that radial tuberosity. And it may not be that obvious when you look at it that the muscles moved up the arm. And in fact, it's common to have a high-grade partial injury where when I fix those, I can literally take my finger and pop the last few fibers off. And when those get missed, they tend to turn into a chronic, painful problem, a little tougher to repair down the road. MRI typically is not necessary, but if there's a significant question, you can confirm the diagnosis. But most of the time, this is a clinical diagnosis, and oftentimes it's pretty straightforward, doesn't need an MRI. A comparison here I wanted to make was a proximal biceps tendon rupture. Completely different animal. Distally, it's an acute injury, a significant injury, mechanism of injury. They hurt a pop, you know, they'll get ecchymosis, they're swollen there. Proximal biceps tendon rupture is the long head of the biceps. Remember, that goes right through the rotator cuff. And so as the rotator cuff undergoes attritional, degenerative changes, that proximal biceps tendon's right in the middle of it, and it's going to wear, and it'll rupture. And it's a fairly common problem. And that's the patient that comes in with a Popeye muscle, because when you rupture your long head of the biceps, it retracts distally, and they've got a Popeye muscle. And they'll see it, and you'll see it. It's very obvious clinically. That's a leave-it-alone injury. That does not need to be repaired. First of all, it can't be repaired. There is no possible way to take that ruptured tendon and bring it all the way back up through the rotator cuff and attach it to the glenoid. It's impossible. I mean, it's not a cut. It's worn, and you're missing 2 or 3 centimeters of tendon, and there's no reason to do it. It's a biceps because there's 2 heads, the long head and the short head. The short head is still attached to your coracoid. It doesn't need surgery. Some people get hung up on the cosmesis. You can take the tendon and do a tenodesis, and you're actually moving it, sticking it, putting it in to the proximal humerus. I mean, it's doable, but it's really unnecessary because there's really no functional deficit from a proximal biceps tendon rupture. And really the issue is the rotator cuff pathology. If they're having shoulder pain, which they may well, and I'll ask them on a proximal biceps tendon rupture, you know, has your shoulder been bothering you? And they'll go, yeah, it's been painful for quite a while. Well, address the rotator cuff pathology. And sometimes they'll actually have relief of the pain when they've had a tendon that's ready to rupture. It finally goes, and they'll say, well, actually, it feels a little better now after a few weeks. But you can reassure the patients, really referral is not necessary, in my opinion, with a proximal biceps tendon rupture, and say, it's not going to affect your strength. It's going to be sore for a while. You're going to have a Popeye muscle. And there's really no reason to repair it. So an interesting comparison. One surgical, really ought to be addressed. It's hard to fix a distal biceps tendon rupture 6 months out. Very, very hard. And it can be done within 2 weeks. And really, I've done them out 6, 8 weeks, even 3 months. But a distal tendon referral within 5 to 7 days is great. 2 weeks, it's still easy to repair. And another comparison here I want to make is a jammed finger, a PIP injury. Kind of a confusing chart here. We'll have some pictures next. This is an interesting one because volar plate avulsion fractures are very, very common. I jam my finger and there's a chip fracture. And it's funny how people get obsessed with the chip. They come in to see me, all they want, they said there's a chip. There's a chip in there, there's a fracture, and they're totally focused on that. And that chip is virtually meaningless. All that chip does is it says the ligament was avulsed. The volar plate is the ligament on the palmar side of your PIP joint that keeps your finger from hyperextending. When you forcefully hyperextend it, it avulses that volar plate. And it pulls off a little chip of bone. Buddy tape is all it needs. It really doesn't need, it's funny how patients, and we put these little alumiform splints on them, and I really don't care for those because it turns the finger into a target. It keeps the finger straight. And I promise you, everyone I see that comes in with those, they're banging their finger because every time they move their hand, they can't get it out of the way, and they're whacking it on things. And it's tender, and we've done something to them or for them. We've given them a splint, so they feel like they have their antibiotic prescription, they have their splint, they're happy. But it's really not helpful in this injury. All they need is buddy tape. And I kind of explain to them so they don't say, boy, I paid $40 for an office visit and gave me a piece of tape. And explain to them, I could have a $500 splint made in therapy that's nowhere near as effective as the splint sitting right next to the injured finger. Tape it to that finger. It prevents the injured finger from being hyperextended. It protects it. It allows motion. The enemy with the volar plate avulsion injury is that they'll get stiff, and that's the thing you have to watch for. So you can buddy tape them right off the bat, reassure them, start moving your finger, it's going to be tender for a few days, and let them go. Now, what you don't want to miss is the fracture dislocation, because that's a significant surgical injury. And the mechanism of injury can be a little confusing, but here's a comparison where it's a little hard to see, but there's your evil chip. And don't you have to take that out? I mean, you're just going to leave it in there? Reassure them that little chip is going to be just fine. It's in the middle of a ligament, and it's going to reattach. And interestingly, not only does it reattach, but the problem is it reattaches with a vengeance. And as it heals, the most common problem from this volar plate injury is a flexion contracture. It doesn't lead to an unstable ligament. It does the opposite. It scars down so tight that they end up 3 weeks later with a finger. I saw a kid with a 70-degree flexion contracture of his finger from one of these because he didn't stretch it out. So typically, I'll put them in buddy tape right away. There's no need to refer this. And then check them in 3 weeks, or if they're reliable, say, listen, in 3 weeks, if you can't straighten that finger all the way, you come and see me, get them into OT, they'll get a little splint to stretch it out. The fracture dislocation, here's 2 different examples, is a different animal. The joint is actually here. You're only going to see here's one with maybe 2 millimeters, 1 to 2 millimeters involved. The joint's still reduced. Here's a 1 millimeter chip. Here, you've got 30-40% of the joint. This one's obvious because it's fallen off the back. Here, again, if you look, it's not a nice congruent joint. It's still subluxing off the back. You've got this kind of comminuted impacted fracture here. This is surgical. It's a problem. This one doesn't even need a referral. So the keys are, this is subluxed. It's involving more than 2 or 3 millimeters, probably 40 to 50% of the joint. And it's a more serious injury. That is an impacted injury, like a pylon fracture and a tibia. This is simply a hyperextension injury. So we'll plow ahead here. Here's the little fixator we'll put on to reduce those repair for the fracture dislocation. And they heal up quite nicely if you catch those early. But it's fairly easy to miss those fracture dislocations and either not x-ray the finger or assume it's a jammed finger. And that's a bad problem. They will develop stiff arthritis and a bad outcome if that's not treated soon. And there you go, your treatment for a volar plate buddy tape. Here's an interesting problem, mucus cysts. These are fairly common. This particular picture I have, here's the cyst right here. Heberden's nodes are very common. Everybody gets a few bumps on their fingers, and their grandma had crooked fingers, and does that mean they're doomed for life to have deformed hands? No, you get bumps on your fingers or Heberden's nodes, little osteoarthritis, and the mucus cyst is a ganglion. Just like a ganglion on your wrist, Baker's cyst on your knee, it's coming from a joint. And so my pet peeve here is these things get treated fairly commonly with freezing them. And that makes zero sense whatsoever. And sometimes people think they're warts, or I don't know what they're thinking. It's not a cutaneous lesion. It is fluid from the joint leaking out, creating a cyst under the skin, and they can be kind of translucent. They can stretch the skin to where the skin's paper thin. And when I take these out, it's always a concern that that skin's going to slough. And so one of the most unhelpful things in the world is to burn that skin ahead of time so that when they come in, they have an open ulceration. And remember, you've got a joint deep to that ulceration. That's where it's coming from. And you've now got a significant risk for a septic arthritis. And patients really have a tendency to not be able to leave these alone, and they got to poke a sewing needle in them. And that's another problem. They assume it's just a little subcutaneous problem. It's a joint. It comes from the joint, and you have to respect them. Because you can get a septic arthritis out of this. Trigger fingers, pretty common diagnosis, pretty straightforward. The thing I wanted to mention on the trigger fingers, cortisone injections really are pretty worthwhile there. You can get up to 60-70% cure rates with one cortisone injection. If they have diabetes, where are we at? 5, thank you. Diabetes, that prognosis is significantly less, probably 30 to 40%. Long-term cure if you inject a trigger finger with diabetes. Here's the technique for injecting. My finger's not actually, whoops, back up here. Finger's not actually on the needle there, but you inject the A1 pulley sits right here. On clinical exam, you're going to find they're tender in that area, and you inject right in and around that tendon sheath. I use about a half cc of steroid, half cc of Marcaine. I warn them, it's a tender injection. They will not like that injection, but it's very effective. And I do percutaneous release on these in the office. Has worked out pretty nicely, where we're able to release it with the needle surgically and not actually make an incision. You can go through the skin and actually with the tip of a needle cut that pulley, and pretty quick recovery. Charging head, whoops, the slides are out of order. There's the mucus cyst, and the example of really what I don't want to see is this open ulceration where someone has burned the skin with cryotherapy, where it creates a problem. Dupuytren's disease shows up as either a contracture, lumps, bumps, pits in the palm. A key here is the diagnosis is pretty straightforward. It's got a little longitudinal cord there and maybe lumps and bumps right about over where you see a trigger finger around the A1 pulley. And this really does not need a referral if they can put their hand flat on the table. I mean, it's that simple. If they don't have a contracture beyond 30 degrees, reassure them what it is. If they can put their hand flat on a table, they don't need surgery, they don't need treatment. We don't take the nodules out, we don't mess with it unless it's bypassed 30 degrees. So another case, a fairly simple diagnosis that you can reassure the patient, say, come back and see me, or we'll send you to the hand surgeon if you can't put your hand flat on the table. Slack and snack wrist. Real quickly, this is an interesting diagnosis because the confusing point is everyone sees the scapholunate dissociation and tends to get an MRI because it's a ligament injury. This is actually the most common form of arthritis, and I'll see MRIs on a wrist like this where there's no reason in the world to get that. This is arthritis. The horse is so far out of the barn, he's down the street and across town. The ligament injury is irrelevant. You would never repair this ligament. It simply is an attritional rupture of that ligament and arthritis. There's no joint space. And so the diagnosis is simply made on a plain film. And this is interesting. It's a little more subtle. But here you've got a scapholunate dissociation, already sharpening, osteophyte here, getting decreased joint space here. Again, I would never bother with an MRI on that. You treat the arthritis. And as long as conservative treatment is working, it's non-surgical. When it gets painful enough, you do a partial wrist fusion. Here's its cousin, is a chronic scaphoid non-union, which leads to the same pattern of arthritis. And here it is, a patient, interestingly, I saw 3 years ago, didn't want to get it fixed, and within 3 years has had some pretty significant progression of the post-traumatic arthritis. When that post-traumatic arthritis gets bad enough, a very effective procedure is we take that scaphoid out and then fuse that mid-carpal joint. They lose about 50% of their motion, but by that time, the arthritis has usually taken 50% of their motion. Perilunate injury is a fairly rare but pretty significant injury. I saw 2 of these in a week in young people from southern Utah, motorcycle accident, ATV accident. Both were missed in the ERs. One of them had long-term median nerve damage because they had an acute carpal tunnel. They had an associated scaphoid fracture. Everyone saw the scaphoid fracture, put it in a splint, said you'll be fine, fix it later. They had a perilunate dislocation. Here, sorry, that's a little dark, is the dislocation where it's a little subtle, but things just don't line up here. You don't have 2 nice smooth rows. And after reducing it, you can see the gap there. That's an acute scapholunate dissociation. Now, if we go to the lateral, that's the key. Here is a lunate. It's an empty cup. It's sitting out in front of the capitate. And if you see that empty cup and nobody's in it, that's a problem that needs to be reduced. We fix them about 5 to 7 days out, but you'll do an emergent closed reduction because they're at risk for acute carpal tunnel syndrome. Here it is out, there it is reduced. So here's the diagram again, shows you've got to push that capitate back up into the cup and reduce that thing. Carpal tunnel syndrome, my only comment here is I see a number of patients sometimes told they have carpal tunnel syndrome just because they have wrist pain. And remember, carpal tunnel syndrome is a nerve entrapment. It's night pain is the hallmark, and numbness and tingling. Not always, most people don't tell you I have numbness here, here, and here. They'll say I have it in these 2 fingers here. That's the most common, probably because they're the most superficial fibers as they go into that transverse carpal ligament. And conservative treatment certainly start out with a night splint. Steroid injections are fine. Warn people they're always temporary. There's some nice studies that show if it's been longer than 3 months, it's not really any long-term benefit, but it definitely gives them some short-term relief, and it may last for 6 months, so it's certainly worth offering. I do these endoscopically, and the long-term outcome is about the same, whether you do them endoscopic or open. The advantage is just a little quicker recovery and a little less invasive with endoscopic. So kind of an overview of some of the less invasive procedures would be percutaneous trigger fingers, endoscopic carpal tunnel, can take a ganglion out on the back of the wrist with a scope. Scaphoids can be fixed percutaneously with a screw. And with the Dupuytren's, recently, in the last couple of years, they've released collagenase. It's been approved, which is another option to address a Dupuytren's contracture. So I'm heading over time, so any questions? There we go. This is a guy from Wyoming. I didn't see this, but a friend, a hand surgeon, sent it. Was bit by a rattlesnake and kept working out on the oil rigs, and eventually came in and said, "Gee, I got a problem with my thumb here." So, not exactly your typical overuse fibromyalgia type injury. Any questions at all? We're good.